Welcome. This module is an introduction to best practices in providing medicated assisted treatment for opioid use disorders. We will begin by looking at the problem of opioid use disorders in the U.S. We will review some statistics and briefly look at some of the measures taken to combat this crisis on both the national and state levels. We will review the criteria for diagnosing substance use disorders and the significant comorbidity that exists between substance use and mental health. From there, we will go on to discuss the options for medication-assisted treatment, standards for best practices, and then we will finish up by learning about one treatment model that has shown tremendous success in a Western Mass community. But before we delve into the material, it is helpful to review the learning objectives for this module. By the end of this hour, we hope that you have gained a greater understanding of opioid use disorders, are able to identify FDA-approved medications for opioid use disorder, and can identify best practices in using a medicated-assisted treatment approach. Before we look at the statistics, let's make sure we're all on the same page as to what substances are included in opioid use disorders. They are prescription opioids such as hydrocodone, also known as Vicodin, oxycodone, OxyContin, Percocet, oxymorphone, morphine, codeine, and prescription fentanyl. Heroin, which can be smoked, snorted, or injected, is also an opioid, as well as illicitly manufactured fentanyl. We've been seeing more heroin laced with this illicit fentanyl in recent years. Prescription opioids used for pain relief are generally safe when taken for a short time and as prescribed by a doctor, but they can be misused. People misuse prescription opioids by either taking the medication in a way or dose other than prescribed, taking someone else's prescription medicine, taking the medicine for the effects it causes, so in order to get high. When misusing a prescription opioid, a person can either swallow the medicine in its normal form. Sometimes people can crush pills or open capsules. They'll dissolve the powder in water and inject liquid into their veins. Some also snort the powder. So according to the U.S. Department of Health and Human Services and the National Institute of Drug Abuse, every day 116 people die in the U.S. after overdosing on opioids. In 2016, we saw more than 42,000 Americans die as a result of an opioid overdose. For many, we know the opioid use or misuse began with prescription medications. Roughly 21 to 29% of clients prescribed opioids for chronic pain end up misusing them in some way. And between 8 and 12% go on to develop an actual opioid use disorder. An estimated 4 to 6% of those who misuse prescription opioids then transition to using heroin. About 80% of people who use heroin first misused prescription opioids. Opioid overdoses increased 30% from July 2016 to September 2017 in 45 states. In response to what is being called an opioid crisis, we see significant efforts being made at both the national and state levels. Nationally, the U.S. Department of Health and Human Services is focusing its efforts on 5 major priorities. These include improving access to treatment and recovery services, promoting use of overdose reversing drugs such as naloxone, which we all, I think, know more as Narcan, strengthening our understanding of the epidemic through public health surveillance. They're providing support for cutting-edge research on pain and addiction, and advancing better practices for pain management. The National Institute of Health, a component of the Department of Health and Human Services, is the nation's leading medical research agency, helping to solve the opioid crisis via discovering new and better ways to prevent opioid misuse, treat opioid use disorders, and manage pain. In the summer of 2017, NIH met with pharmaceutical companies and academic research centers to discuss safe and effective non-addictive strategies for managing chronic pain, new innovative medications and technologies to treat opioid use disorders, and to improve overdose prevention and reversal interventions to save lives and support recovery. In April of 2018, the National Prescription Drug Abuse and Heroin Summit, the NIH director together announced the launch of HEAL, Helping to End Addiction Long Term. This initiative is an aggressive trans-agency effort to speed scientific solutions to stem the national opioid public health crisis. At state levels, we see different things happening. Some states have established legislative and executive task forces to focus on opioid crisis. Many states have released medication prescription guidelines. There's also more prescriber or provider education around core competencies for the prevention and management of substance misuse. There's public information campaigns through state departments of public health, which are trying to bring greater awareness to all citizens. The passing of naloxone access laws, this is again Narcan. You may know that it's a prescription medication that reverses the effects of an opioid overdose. It has become an essential tool for providers and prevention programs aiming to prevent overdose, death, and disability. All 50 states allow medical providers to prescribe naloxone to patients who are at risk for an opioid overdose, including those in outpatient treatment for opioid misuse or who take high doses of prescription opioids for medical conditions. However, many individuals who are most at risk for an opioid overdose do not have regular contact with health professionals and would benefit from alternative means of obtaining naloxone. Many states allow prescribers to write naloxone prescriptions for people who are likely to encounter a person who has overdosed. So in most states, this includes family members, friends, or professionals who work with at-risk individuals. I encourage you to log on to your state's website to find out what efforts are being made at your level around the opioid crisis in your state. So these interventions help, but there is still more to do. So why are we here? Why are you listening to this module? We hope it is so we all can have greater understanding when it comes to preventing and treating opioid use disorders. We know that with greater understanding, we help reduce stigma, we can develop a unified message, and we can better coordinate our efforts, especially among the different disciplines who engage this population. As trusted healthcare providers, it is our duty to work together to share best practices, increase awareness, promote education, and improve treatment through a unified approach to combating this epidemic. For the next few slides, we will be defining substance use disorders and addiction. As defined by the American Society of Addiction Medicine, addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. It is a biologically based disorder. Addiction is a chronic brain disease characterized by a dysfunction of the brain's reward center. When an addicted person uses their drug of choice, the reward center is activated at much higher rates than with a non-addicted person. The drug use escalates as tolerance of the substance begins. Eventually, the person is willing to do just about anything to both avoid painful withdrawal symptoms and experience the euphoric high of use. Those struggling with addiction are not bad people. They are not immoral in any way. They are sick with the disease of addiction. Contrary to popular belief, an addicted person cannot just stop, and it is not an issue of willpower or lack of conscience. Addiction is much more complex. So we know as a brain-based disorder, problems manifest biologically, psychologically, socially, and spiritually. This is reflected in an individual pathologically like pursuing reward and or relief by use of the substance and related behaviors, certainly at the expense of these other areas of life. Addiction is characterized by the following 5 behaviors or symptoms, although we'll look at the actual DSM-5 diagnosis on the next slide. We know that addiction is characterized by inability to consistently abstain, impairment in behavioral control, experiencing cravings, diminished recognition of family problems with one's behaviors and interpersonal relationships, and dysfunctional emotional responses. Like other chronic diseases, addiction often involves a cycle of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. So you may be familiar with the changes that were made to diagnosing substance use in the DSM-5, which was released in May 2013. Among these changes, we saw a significant shift in language, particularly from use of terms like abuse and dependence to substance use. Removal of separate classifications of abuse and dependence occurred because these were based on psychobiological basis of loss of control as a different phenomenon than the behavioral aspects of negative consequences and performing disruptions. So the shift to a continuum perspective of understanding substance use occurred. So now diagnoses fall on this continuum from mild to severe, depending on the number of symptoms a person presents with or reports. So here you see, 1 criteria really means no diagnosis, 2 to 3 is a mild substance use disorder, 4 to 5 moderate, and then 6 or more, somebody would be diagnosed with a severe substance use disorder. And here on this next slide, we see the 11 criteria that are used to diagnose a substance use disorder. Taking the substance in larger amounts or for longer periods of time than somebody meant to, wanting to cut down or stop using the substance but not managing to, spending a lot of time getting, using, or recovering from use of a substance, cravings and urges to continue to use, not managing to do what one should either at work, home, or school because of substance use. Using substances again and again, even when it puts somebody in danger. Continuing to use even when the person is known to have a physical or psychological problem that could have been caused or made worse by the substance. Needing more of the substance to get the effect. So obviously tolerance, building tolerance. Tolerance is defined by either a need for a markedly increased amount to achieve intoxication or desired effect, or markedly diminished effect when continued use of the same amount. This does not apply. The diminished effect part does not apply when used appropriately under medical supervision. Development of withdrawal symptoms, which can be relieved by taking more of the substance. Withdrawal manifesting either characteristic syndrome or the substance is used to avoid withdrawal. So again, this doesn't apply when appropriately used under medical supervision. So as we saw on the last slide, depending on the number of criteria, a person may be diagnosed with mild, moderate, or severe substance use disorder. So why does substance use develop? The answer to this is very individual, but we know that mental health and substance use have a strong overlap. 53% of individuals with a substance use disorder also meet criteria for a mental health diagnosis. 45% of Americans seek treatment. Those who seek treatment have a dual diagnosis of substance use and mental health disorders. Many share experiences of trying to self-medicate mental health symptoms, and so maybe this is where their substance use begins. Often in our culture, this can be supported. Somebody may say, just have a drink, it will help calm your nerves, or If you use this, maybe you'll feel more relaxed or social, not realizing that for any given person, this may lead to a substance use disorder or contribute to. Self-medication certainly can lead to overuse and addiction. And there's a great deal of stigma that continues to exist for both mental illness and substance use, which seems to keep the two even more separated, even though there's such a high comorbidity. While both are recognized as biological problems, there continues to be significant fear and judgment within our society, which certainly can impact seeking treatment for one or both. It's important to note that mental health and substance use disorders were treated separately until the 1990s. That was considered, best practices then, and there was the shift in the 90s where we saw some movement from sequential treatment being the norm to no longer having a hard line between diagnosis or treatment, and that we wanted to have more of an integrated approach. Integrated approaches to treating mental health and substance use disorders are considered best practices today. And we know that no single option for every combination is best, that we need to personalize treatment for the individual we're working with. So an integrated dual diagnosis treatment approach, often delivered in one setting or in a highly collaborative approach among providers in different settings, is ideal. Although this shift happened in the early 90s, I think we're still pushing to make progress to truly see the two as being treated in an integrated way. So standard of care is to begin mental health treatment at the same time as substance use treatment. We don't know what came first, and often it doesn't really matter. Certainly we want providers to be using their clinical judgment in relation to the type of work that's being done. So perhaps if somebody has a trauma history, not delving deep into the trauma work while there's active substance use. But the point is that we don't have to wait for one to resolve before beginning to treat the other. So there's a combination of treatment approaches. Certainly there's medication, there's behavior modification, there's coping mechanisms, and then modification of traditional techniques, helping people build social skills, build relationships, and not necessarily, we want people to avoid social situations that could lead to further substance use or continued substance use, but not necessarily avoid relationships altogether. For both mental health and substance use, we know that early treatment is key. An integrated approach is necessary. Recovery occurs over months to years, and we'll talk more about that later when we look at medicated assisted treatment more in depth. And a long-term community-based approach is needed for success. We will see when we look more closely at medicated assisted treatment that the use of medications are most successful over longer periods of time. Recovery is a process and one that requires support, emotional, social, and physiological. It's also important to note that in addition to mental health comorbidity, many individuals have physical or medical conditions that may either contribute to the development or maintenance of a substance use disorder and or are impacted by or may ultimately manifest because of the substance use disorder. So in addition to mental health comorbidity, often there's a co-occurring physical health problem. This is why an integrated approach is so crucial. So in the next several slides, we will look more in depth at the types of medicated assisted treatment and how it works. So we know addiction is a disease, right? I know you've heard this before. Anyone who's tried to quit smoking knows this. Even if you've tried to lose weight or kind of start any major change, you know that any change, even when it's not kind of hijacking our biochemistry, is tough to make. So I'm going to say something that sounds radical at first, but hear me out. The drug is not the problem. There are many people out there who are living more functional lives thanks to opioids taken in conjunction with thoughtful medical care. So hear me on that one. In conjunction with thoughtful medical care. And these individuals certainly might have tolerance. The medicine might not be working as well as it used to, and they might have dependence. They would certainly notice withdrawal if they suddenly stop taking the medication. But this is not addiction. Addiction is the dysfunction that comes from misusing a drug. For example, babies might be born opioid dependent, but they're not necessarily addicted. Their lives are not being ruined by the substance in the sense of the behaviors that contribute, like stealing from loved ones to support a habit. So keeping in mind that people can, in functional ways, under the care of a medical professional, be on prescription opioids and have it be working well for them and not contributing to a substance use disorder. We also know that treatment works. People do heal from this. They can enter lives free from addiction. There are many paths to this, but one that has been well studied and found to be the most effective is medication-assisted or medically assisted treatment, or more kind of commonly known MAT. It works for far more people than counseling alone or, say, a 28-day rehab stay, than anything else that we have studied. So addiction and the recovery process are commonly marked by strong cravings to use even after successful completion of detox and treatment. These cravings, a normal occurrence for those struggling to get and then stay clean, can interfere with treatment and increase the risk of relapse. Fortunately, certain medications have proven very successful in helping to stave off these cravings and promote abstinence. According to the Substance Abuse and Mental Health Service Administration, use of FDA-approved medications in combination with evidence-based therapies can be effective in the treatment of addiction and may help recovering users stay in treatment longer, extending periods of sobriety and paving the way for successful recovery. MAT is the combination of medications with therapies that teach the recovering person how to manage cravings and triggers for relapse on a cognitive, emotional level, and promotes extended periods of sobriety. This combination of therapies is known as medication-assisted treatment. It is not the use of medication alone. While for our purposes we are focusing on opioid use disorders, it should be noted that MAT is also commonly used for alcohol use disorders as well. So why use medication? Many people believe that using medication in treatment of substance use disorders is trading one addiction for another. But this slide and the following slide display evidence as to the benefits of this treatment approach. On this slide, you see the first graph here on the left-hand side. It is one of the most striking graphs on this point. This is from one of the first studies looking at buprenorphine, also known as Suboxone, in people addicted to heroin. The comparison group was receiving intensive counseling. The buprenorphine group received counseling and buprenorphine. As you can see, no one stayed in recovery very long with detox and counseling alone. In fact, 3 of the people in the study died from overdoses who only received detox and counseling. In the buprenorphine group, no one overdosed, and after 1 year, only 20% had relapse. That's 80% of individuals had maintained sobriety. Now, this is just one study, but in 2017, a group of physician researchers combined all the published data together in one giant study called a meta-analysis. The life-saving effect of methadone and buprenorphine becomes quite clear. This shows, and you see here on the graph on the right, this shows the difference between being in treatment on medication versus people when people stop the medication. In both groups, the overdose death rate was much lower than when people stayed on medication, but in general, the risk of death from overdose is less than 1/3 of what it was out of treatment. So obviously we have the benefits of helping people to get and remain clean with medication-assisted treatment. We know that it helps save lives. So here we see, in addition to that, medically assisted treatment reduces drug use by both, our total amount used, number of days and months used, number of weeks with any drug use. It protects against overdoses, it prevents injection behaviors, and it reduces interactions with the criminal justice system. As we have stated, this is not a standalone treatment. Each medication should be provided in addition to recovery work with intensive psychosocial and behavioral therapy. We've touched upon this, but it's an important point. MAT is considered a long-term treatment. While there's no evidence for a predetermined length of time, it has been found that individuals benefit from engagement with MAT for a minimum of 1 to 2 years of sobriety before attempting to taper, with dosing reassessments every 6 months. So we know that longer retention equals better outcomes. So as a review for medically assisted treatment, best treatment of addiction, it is known to be the best treatment of addiction, is to combine medication and therapy. It results in better outcomes with fewer deaths. MAT is not trading one addiction for another. Many types of counseling can be effective, and there are several options for medications, which is great because, coming back to best practices, we want things to be individualized, right? This provides people with options. Personalization is key to success. This is not one-size-fits-all treatment. There are 3 classifications of medications for treating opioid use disorders. The first is a full agonist, which means increasing doses of full agonists produces increasing effects until a maximum effect is reached, that the receptors in the brain becomes fully activated. So it's similar to heroin. We also can see this with methadone, that people are getting or can get full effects from the medication. There's also a partial agonist. This group shares some characteristics of full agonists. At low doses, full and partial agonists produce effects that are essentially indistinguishable. However, increasing the dose of a partial agonist does not produce as great an effect as that which results when increasing the dose of a full agonist. There is a ceiling to the partial agonist effects. So an example of this is buprenorphine, also known as Suboxone. We'll talk more about this in a couple slides. And then the last group is antagonists. They also bind to receptors in our brains, but rather than activating the receptors, they block receptors by preventing them from being activated by an agonist compound. It is as if an antagonist is a key that fits in a lock but does not open it. It also prevents another key from opening the lock. When people take an antagonist and then an agonist, they do not feel the effects of the agonist medication. So, for example, clients who take naltrexone, which is better known as Vivitrol, they will not feel the effects of heroin or other agonist medications or methadone if they take them after taking naltrexone. So we've talked about the benefits in general of medication-assisted treatment, but what options are out there? The most well-known, we'll start kind of midway down, is methadone. Medication requires a special license, a special clinic, and generally comes with some tight restrictions. It is a great option for some, but some folks find that needing to go to the clinic for a dose of medicine every single morning really impairs adapting to, quote, normal life. Others find that the structure and routine is key. Over time, clients may have an option of getting what are called take-homes, which means that they don't have to go to the clinic every day to get their dose. This will depend on length of treatment, sobriety, and clinic rules and regulations. If a person has an option to have take-homes and for how long. For some it may just be a day or two. For others, they may be able to take a 10-day vacation and have take-homes for that time. So it really varies on the individual and the clinic. The second option up here at the top is buprenorphine, better known by the brand name Suboxone. It is a partial agonist and also can be a partial agonist and antagonist, which means that there is a limit to how much it can impact your brain receptors. So think of it this way: heroin or fentanyl will hit any and all of your opioid receptors in your body and kind of blow them wide open 100% very quickly. If this happens to too many of your receptors, you overdose and you may die unless someone provides a rescue medication. Buprenorphine will open many of your receptors, maybe about 40%, and then it stops them right there. If an individual relapses and uses a bag of heroin after taking their buprenorphine earlier in the day, it will block the effects of the heroin. Because of this level of safety, medical providers can prescribe this from their offices, and this brings addiction treatment to a place where you can treat it more like a medical condition, like say diabetes or something, than a stigmatized special condition that needs a special other clinic. Lastly, there is naltrexone. Think of this as long-acting naloxone, aka Narcan. The most commonly known naltrexone is Vivitrol. It is a strong blocker of all opiates. It can come in once-a-day pills and in monthly injections. This was first studied in alcohol use and is reasonably effective. It can also help with actually overeating, marijuana use, and even some other behavioral addictions. It does work better than counseling alone, but not as well as the first two medications mentioned. Individuals have to be completely detoxed and out of withdrawal before they can start this medicine, which few people do outside of a controlled setting. It's more commonly used after inpatient drug rehab and with folks who are leaving jail or prison. As mentioned earlier, MAT is also used for alcohol use disorders. The medications for those are commonly known as Antabuse and Campril. So, advantages of buprenorphine. So again, it's a partial opioid agonist. It's used to treat someone who's addicted to an opiate, whether the substance is heroin or prescription pain medication. Of the few medications used to treat opioid dependence, buprenorphine is the first that can be prescribed for and obtained directly from the doctor's office. To date, other drugs used to treat opioid dependency, such as methadone, can only be administered in clinics. The Drug Addiction Treatment Act of 2000, also known as DATA 2000, enables qualified physicians to prescribe and/or dispense narcotics for the purpose of treating opioid dependency. For the first time, physicians are able to treat this disease from their private offices or other clinical settings. Patients can now be treated in the privacy of their doctor's office, as are other people being treated for any other type of medical condition. So it really does help with stigma. The increased access for buprenorphine reflects a change in the level of urgency that the opioid epidemic presents to the medical community. It's one that demands broadened patient access to opioid dependency medication and other forms of treatment. Buprenorphine isn't prescribed in isolation. It's one component of a comprehensive recovery program designed to address patients' individual needs. It's important to note that buprenorphine alone has potential for abuse and prescription diversion due to its opioid effects. However, formulations that contain a combination of buprenorphine and naloxone decrease the potential for abuse because naloxone otherwise blocks a robust opioid effect, and further will initiate withdrawal symptoms if attempts are made to misuse it via injection. So a lot of times we'll see kind of this combination of the partial agonist and the antagonist medications. When used properly, these buprenorphine-containing medications can both alleviate unpleasant opioid withdrawal and decrease associated cravings. These medications are also difficult to overdose on due to the ceiling effect that buprenorphine has and to the opioid antagonism of naloxone if the combination formulation is prescribed. Once you reach a certain dose, the effects plateau and don't increase with higher doses. So as a review, the benefits are, less severe dependency, allows for an easier transition between recovery with and without the medication. Partial agonists are safer with less overdose potential. There's lower potential for overuse. People can live a typical life free from cravings and withdrawals, and it saves lives. As with any medication, certainly there are limitations and side effects. Here we see some of the potential side effects of buprenorphine: fever, irritability, sleeping difficulty, vomiting, constipation. It's important for people to know about the side effects and kind of anticipate those and talk with their doctor about how long they may last, because certainly side effects can be a barrier to continuing the medication and the treatment. Since the medication, buprenorphine, is a partial opioid agonist, the side effects are similar to those of opioids, such as heroin and prescription painkillers. And so for limitations, because it's not a full agonist and it may not retain people in treatment as well as a full agonist because they're not getting kind of that effect initially and maybe experiencing some minor withdrawal or some minor cravings early on. Has diversion potential and certainly could be misused. It does have that potential. Medication is expensive and access is limited for some people. And stigma within the recovery community can exist around use of medications. So looking at methadone, again, it's the full opioid agonist, which means that it produces similar effects to other opioids. However, because it is longer acting than drugs like heroin, the effects are milder and shouldn't significantly impact the individual's ability to function. Methadone is used to alleviate withdrawal symptoms and drug cravings in those addicted to heroin or painkillers. In fact, one dose can prevent cravings and withdrawal for up to a day and a half, according to the Center for Substance Abuse Treatment. In order to prevent abuse, methadone is administered in a clinic on a set schedule. Despite its relatively mild effects, no extreme highs associated with it, those taking methadone would likely still experience unpleasant withdrawal symptoms if methadone therapy were to suddenly stop. So it's important to make sure clients speak to their doctor if they want to go off methadone at any point. So studies show that 70% or more treatment retention at 1 year's time, so people are staying engaged in treatment. It does treat cravings, it blocks illicit opioid use. So if someone's on methadone and then takes heroin, the effects of the heroin will be blocked. Over 40 years of research and treatment experience demonstrate the effectiveness. So this is the longest used and longest studied medication for opioid use disorders. It significantly reduces the risk for addiction related to death and health problems. The medication cost is actually minimal and not listed here, but again, it saves lives. So some common side effects of methadone, again, pretty similar to side effects of opioids like heroin or prescription pain meds: dry mouth, sweating, sleep disturbances, mood changes, reduced sex drive, and so forth. So these side effects may be somewhat troubling, but rarely present any danger. One should seek medical attention immediately following more serious side effects like itching, seizures, rash, swelling of the face, hallucinations, severe drowsiness, and breathing difficulties. The limitations of methadone, certainly as a full agonist, there's a greater potential for overuse. There's a potential for dangerous interactions with other drugs when misused. It's highly regulated, which can result in limited access to care for some people. Strong physical dependence results in a difficult withdrawal, and this is particularly where tapering after a length of time kind of stable on it is so important. Significant stigma within the community, and a heavy burden on clients for compliance. So we had talked about earlier having to go every day to a clinic and receive the dose. That certainly can interfere with someone maintaining the program. And then we have the advantages of Vivitrol or naltrexone, which can come in an injectable or pill form. Vivitrol is the injectable version. It's used to treat either addiction to either alcohol or opioids. It may be the injection can be administered intramuscularly and therefore only requires monthly dosing, which can be very helpful for people. Oral dosing occurs once a day. Unlike buprenorphine and methadone, naltrexone lacks potential for diversion and abuse. People will not get the kind of effects or get high off Vivitrol. So naltrexone, Vivitrol work by blocking the opioid receptors. As stated earlier, if you take the drug and then take alcohol or opioids, you won't experience the usual euphoria or high associated with those substances. It may also decrease the general urge to use opioids or alcohol. It's important to note that naltrexone decreases your tolerance to opioids, so relapse can be really dangerous if a person returns to taking the amount they once did. Overdose and fatal respiratory depression may result. So the benefits really: safe to use, no abuse potential, blocks the effects of opioids, reduces danger of accidental overdose, no physical dependence, and little or no stigma for it in the recovery community. It does have some side effects like any medication. See those here. Again, nervousness, vomiting, muscle aches, difficulty sleeping. And in terms of limitations, it's less researched and there's less clinical experience in prescribing Vivitrol, so we don't know as much about it, and we don't really have long-term evidence for it. There's no reinforcing effects to support retention in treatment. There's no withdrawal symptoms to prevent treatment dropout, and high costs may limit access. It may not control cravings, and people must be opioid free to begin. So it's indicated for relapse prevention. So it's for those who are already detoxed and maybe have already gone through a buprenorphine treatment or a methadone treatment, and are going to use this for prevention relapse. So it's important to keep in mind, again, that MAT is a longer term treatment, and so to keep that at the forefront when thinking about tapering. Typically, individuals with continuous sobriety for 1 to 2 or more years have the best outcomes. Treatment that's been like less than 6 months has had worse outcomes. There's actually no evidence to support stopping MAT. 95% of methadone patients do not achieve abstinence when attempting to taper off, according to a study in 2013. And then a 2011 study showed that over 90% of buprenorphine patients relapse within 8 weeks of a taper completion. So successful patients are commonly maintained on methadone for 24 plus months and buprenorphine for 18 plus months before even beginning to taper. So I just think, the major takeaway here is engagement for long periods of time before beginning to taper and then going very slowly at that point. So here we are going to, sorry about that, see a video to conclude. We're going to watch this video. The video introduces you to Patrick LaFond. He is a PA at a local Suboxone clinic called the Healthy Living Program, which has locations in Northampton and Indian Orchard, Massachusetts. The Healthy Living Program is a comprehensive treatment program that utilizes evidence-based protocols to provide up-to-date quality addiction treatment with compassion, understanding, and respect. Their team of providers and behavioral health professionals work together to provide individual patient-centered, medication-assisted therapy to support the recovery of their clients. If you're interested in more information, feel free to visit their website listed here below. After we hear from Patrick, we will look more in depth at the model used at the Healthy Living Program.
Good morning, everybody. I'm Julie Barrett-Abebe, the training coordinator for the Interdisciplinary Behavioral Health Collaborative at Westfield State. And I'm so happy to have Patrick LaFond with me this morning. So, Patrick, welcome. Would you be willing to just introduce yourself?
Sure. My name is Patrick LaFond. I'm a physician assistant. I've been a physician assistant for about 20 years, and presently I work at an emergency department in Springfield, Massachusetts, and also at a Suboxone clinic called On Call Urgent Care in Northampton, Massachusetts.
That's wonderful. Thank you. And you are a resident expert because we've learned a little bit through this training module about opioid use disorders and some of the treatment options that are available. And I'm hoping you could walk us through the treatment model that you use in your clinic.
Sure. So it's mainly a Suboxone clinic or a buprenorphine clinic, and that medication is used in order to basically block the use of opiates along with decreasing any withdrawal symptoms. And then over time, we'll usually taper down the medication once the patient is kind of more stable. And I've worked in another Suboxone clinic prior to this, and so it's kind of a helpful, retrospective look for me to see how different models work. And also, we will also do Vivitrol in the clinic, where that is a shot that people get once a month to block any opiates, but it doesn't help any withdrawal symptoms or cravings.
Okay, great. Thank you for that context. And can you tell us a little bit, I know you have the comparison available to you having worked in different models, what makes your current model unique and maybe more successful?
Yeah, I think it's a lot more successful. It's a small clinic. It's run by very specific people, but one of the most integral parts is not only the provider who can prescribe the medication, but also there's therapists in the building, and there's also a case manager. And so the case manager, we call her the program director. She's able to start with the patient, basically showing them the rules and regulations of the clinic and what is expected of them and they also sign like an orientation manual where it's like a contract of sorts. And then on top of that, she watches those patients from behind the scenes with labs, with urinalysis, urine tox screens, and things like that, and also is touching base with their therapist to make sure they're kind of up to date with everything. And the previous model I worked at didn't have that. We basically, there was no case manager, so the patients were able to come in and see a different provider each week, and so they sometimes wouldn't be held accountable for certain infractions they may have done, so therefore it would prolong their improvement in addiction evolution in their body, if that makes sense.
It does, yeah. So it sounds like this model actually promotes treatment because it helps hold people accountable, but maybe also gives them access to more services that
Right.
then support them in their recovery.
Yeah, exactly.
Okay. Yeah. Can you tell us a little bit more about who are the different professional players in the clinic and how do they support the clients that come in?
Sure. What I'll probably do is I'll just give you a narrative of where the patient goes when they first come in. And so first they'll go into the waiting room. There's a receptionist, and that receptionist will check them in and basically make sure their insurance is verified. And then they'll also make sure that their prior authorization is available for the insurance to be able to pay for the medication. And then they'll be brought in by the scribes, which are also medical assistants. They'll bring them into a room and they'll explain how they're going to collect the urine. Sometimes they're witness, sometimes they're not. It's usually random. And then they'll tell them to leave all their baggage in their room, including coats and things, so that they can't alter the urine, which is a huge offense. And then they'll come back to the room, they'll get vital signs checked, and then they'll see a provider, which is usually one of the PAs in the clinic, sometimes the doctor who's the medical director. And then from there, then they'll see the provider, which is sometimes me, will go in and talk to the patient, and they'll usually have filled out a form which will say if when their last dose was, if they use any other substances this week, and see who their therapist is, and if they have any complaints or concerns, they want to talk about the provider with a provider. So then, as a provider, I'll go in and talk to them and discuss how they're doing, and I'll listen to their heart and lungs and their belly and make sure there's no swelling or any side effects from the medication. And then after I'm done, then the patient will go into a different room with their therapist, and they'll be able to kind of have usually it's half-hour slots, but they'll have a time to be able to discuss things with their therapist. And then at some point, if it's a problem case, the therapist and the provider and the case manager will just quickly have an impromptu meeting about the patient and say, hey, these are things to look out for, or things we can improve upon. So
that's really helpful. It sounds like it's a real team approach.
It's much better and much more thorough than I'd ever seen before. And the good thing is we'll all be involved. So if the patient's not doing well, we can kind of circle the wagons a little better. As a provider used to say, we give them a closer hug. Because if they're doing poorly, we'll have them come more often.
Mm-hmm.
Some patients will come twice a week if they're on a probationary status, or some even 3 times a week. And just to, basically we'll recheck their urine, they'll see a provider again, and so they're basically being held accountable for their actions. And if they continue to do poorly, we may have to suspend them, or we may have to actually hand them off to a methadone clinic, something that's more stringent.
Mm-hmm. So it's almost like a higher level of care because people are being seen more frequently.
Yeah, and we'll kind of usually do it. We'll try to set it up for them when they leave.
Mm-hmm.
And some patients aren't too happy about it, and a lot of these patients have very poor coping skills. So, and they'll their reactions to different models or are holding them accountable is sometimes a challenge.
Mm-hmm. It sounds like that's where therapy might come in too, in terms of promoting better coping, addressing trauma, those kinds of things. And just out of curiosity, does the case manager also coordinate with outside resources? So like being in touch with other collaterals, or, helping people access the other kinds of community resources, or is it more internal? Okay.
Yeah, she'll. So, because there's quite a few patients who have like a psychiatric need, like whether they have bipolar disorder or some other psychiatric illness where they need medications, and so therefore they may be seeing an outside therapist, which is in like Clinical Support Options, for example, has a psychiatrist, but in order to see their psychiatrist, you have to see their therapist. And so they won't see our therapist. And so Lynn, who's our case manager, will basically coordinate with them, make sure that the patient's doing everything they're supposed to doing. If there's any concerns, and she usually has an open dialogue with a lot of those folks. And same with DCF or probation, because there's quite a few of our patients who had legal backgrounds where they've been arrested multiple times and they're on probation, and also with DCF. And we're, of course, mandated reporters, so if we have a patient who's intermittently using heroin and they have children in the house, we have to report, and Lynn is usually the one to do that. And same with pregnancy. If a woman's pregnant and she's on Suboxone, that's a reportable issue. And usually the hospital does that when the baby's delivered. And then Lynn is the follow-up and shows them how great the patient has been doing for the entire pregnancy, that kind of thing.
Okay. Yeah, that's wonderful. And since you were just talking about this in terms of, medication-assisted treatment, I'm wondering what you would say to maybe critics of a harm reduction approach. How have you seen it be successful, and are there ways in which you think it could be more successful for clients?
Well, so regarding harm reduction versus complete abstinence, abstinence is always the goal. In our clinic, our goal is to use the best model for the patient. And so there's patients who are at risk of overdosing and other problems. And so we kind of determine how risky it is. And if they're using a large amount of opiates in a day, it's going to be a very difficult situation to go from that to nothing without having other issues such as withdrawal symptoms, psychiatric relapses. There's a lot of issues. So Suboxone actually decreases a lot of the cravings and a lot of the withdrawal symptoms, and helps them kind of function and kind of get their feet underneath them and be able to have a normal life. And as they're building up their normal life, then we can kind of slowly decrease the Suboxone. And this is legal and medically necessary at the time. And then hopefully they'll be able to get to a point where abstinence is a goal in the future. Other patients, they don't have an opiate dependency per se anymore by the time they come in, and for some of those, Vivitrol is a better option. Specifically, patients who come right out of jail and haven't been able to get opiates in jail, but they know they're at higher risk at home, and you can do Vivitrol, and I use that I call it a safety net, so that they won't fall to the ground like they would have before. And then regarding critics, I mean, I've seen it save lives. I've seen it bring people back from, homelessness and complete despair, and they've improved. Now, were those people, did they have the correct coping skills in order to do complete abstinence at that point? I don't think so. But abstinence is always our goal, if that makes sense.
Yeah, no, I think that's really helpful. And I appreciate too how you highlighted, different people need different things. So to individualize treatment plans depending on people's specific needs. So this can be really helpful for a large number of people, but other things might work as well.
Yeah. It's a challenging situation because in the model of complete abstinence it's a very difficult model because it's kind of like a blanket treatment for everyone, and everybody has unique needs, and I think that's where our model with the case manager comes in handy, and the same model doesn't fit every single person.
Right.
So.
Exactly. Well, that sounds like a perfect note for us to end on. Thanks again for sharing your time and expertise. I really appreciate it, Patrick.
My pleasure. Thank you very much.
Bye.
Bye.
All right, let me just stop the recording here.
So we hope you found that video really helpful. I think it really kind of conceptualized everything that we've been talking about. And so I just want to review some of the points Patrick emphasized in regards to the model that they use in their clinic. First and foremost, consistent with medication-assisted treatment, therapy is mandatory. And so as an example of best practices, this model requires engagement with therapy. All clients have a therapist either on-site or off-site that's familiar with addiction along with mental health. Many clients have past histories of polysubstance use, poor coping skills, previous trauma, along with a family history of addiction. So therapy is a crucial component of this treatment. If clients are not current with their therapy, medication will not be continued. And so that's kind of a hard line. And then the treatment model also encourages group meetings such as intensive outpatient treatment, IOPs, engagement in Narcotics Anonymous, Alcoholics Anonymous, for greater support can always be helpful. So Patrick talked about really the cornerstone of this practice is the use of this case management model where one person in their clinic, it's the case manager, who's also called the program director, at each site coordinates care, keeps clients responsible for their actions, monitors drug screenings, and communicates with all of the different providers. And so the staff, you heard him talk about, really comprehensive. I mean, you have a medical director, clinicians with certifications in addiction, social workers, psychologists, program director, office manager, receptionists, medical assistants, phlebotomists, lab directors. So it's a really integrated approach in terms of the staff that are working with individuals. And then just to note that clinicians do need the data. We talked about this earlier, the Drug Addiction Treatment Act from 2000. They need a waiver for this, which then allows them to prescribe buprenorphine for addiction. The case manager, kind of going more in depth here, monitors the client's commitment to therapy, certainly gets proper releases to be able to communicate with people involved in their life, other service providers that might not be part of the clinic. So keeping in contact with probation officers, staff from the Department of Children and Families if they're involved. Directly communicates with providers if regulations of practice are not being followed, with recommendations to consider, and then participates, and I think this is really important, they participate with the intake with each client along with the medical provider, and that's so that so they're really on the same page and kind of know what's been reported from day one and know this client's history rather than just getting it secondhand or reading the report. So as we've talked about, there's therapists in the clinic. Typically there's about 30 minutes. They have 30-minute appointments, and we'll see clients often when they are present for other provider appointments so that, people aren't coming in several times a week, but trying to really be able to do everything at once if that works for their schedule. This supports the team approach, giving the opportunity to discuss with the provider and case manager, including impromptu consults during the day. Patrick talked a lot about kind of team meetings and all coming together so everyone's on the same page regarding how somebody's doing. There is no psychiatric prescriber in the practice, so some clients are required to see a therapist at the same office where they see a psychiatrist, but they're still included, and the case manager is still connecting with them so that they're part of this treatment team. All parties monitor how well clients are managing life skills such as employment, legal status, parenting, relationships, setting priorities, and again, these are discussed as a team. This is an integrated approach. And lastly, but no less important, the team includes a relationship with the client's pharmacy. For this particular model, the clients have the option of using only 3 local pharmacies, so this helps keep continuity. And then the receptionist can work on insurance authorizations and communicating with insurance companies to make sure everything goes smoothly. And the case manager communicates with pharmacies directly to decrease complications when changing orders or whatever is happening with medication. So this is really effective. So thank you for taking the time to listen to this module. We hope you found the information provided helpful and has given you a foundation to understanding medication-assisted treatment, kind of best practices around that, particularly with opioid use disorders. We look forward to having you join us for additional trainings. And as we close, I would just like to again highlight and have you kind of keep these important takeaways in mind. Medication-assisted treatment is not trading one addiction for another. It consists of a long-term support in the community. Recovery does not happen overnight. It works best when it's individualized. This is not a one-size-fits-all kind of approach. As Patrick had said, we want to find the best model for each client. The MAT approach is when someone's doing poorly, we increase services, not reduce them. As Patrick stated, we give them a closer hug. And MAT requires an integrated and holistic approach. It's about treating the whole person. So it's not just medication, it's not just therapy, it's not just medical care, but it's all of those combined. Thank you.